So let's start about this talk. The first thing I always tell my students when I'm training them is always aim for success. And how do you do that in sinus surgery? Well, the first thing is preoperative preparation. And one of the first things in preoperative preparation is radiological preview. And this is extremely important. But then there are other things that you need to know about the sinuses that get you a successful outcome. And anatomy comes very high up there in our skills if you're going to do very good sinus surgery. And of course, there are considerations that you need to think about in surgery. And of course, post-op care is extremely important for these patients. So the rest of the topics will be for another day, another time, but we're going to spend a lot of time talking about radiology for the next 20 or 30 minutes. So rules to live by that I always talk to my fellows and students about is one perfect surgery is better than five bad surgeries. And when you see these patients who have had previous surgeries, there's a lot of scar tissue, a lot of problems for those patients, makes life hard for you as the surgeon. So one of the things I tell my students is every single thing that I do in surgery, I must have a reason to do it. And if you find that I don't have a reason for it, you must question me. And this is an extremely important rule to live by, because if you don't know what you're doing and why you're doing what you're doing, then there's something seriously wrong with what you're doing. So before you start, review the patient notes and the chart the day before the surgery. Review the CT scan in all three orthogonal planes, and we'll talk about the importance of that in a few minutes. Do this the day before surgery, the evening before surgery. I do this with my fellows the day before surgery, and then do it again immediately before you start surgery. And the importance for doing this is to create a 3D image of the anatomy in your head, because your head, your brain is the ultimate image guided system, not the Medtronic Stealth or whatever image guided system you're using. It's really the ultimate image guided system is your brain. So use a system that you like, anyone that you become familiar with and really learn well, to look at your CT scans and practice with it over and over again. So when you look at a CT scan, think about the system that you're going to use to go through this CT scan. So there's several out there. The ones that I really like to teach with are ones where the mnemonic is close up, fog, and FOD. So close up is one that's very popular that most people use. Every one of those letters stands for a region that you should pay attention to, and all of those are listed on the slide. And then, of course, before you start your CT review, you must know what a window width is and what a window level is. So I'm not sure if everybody knows this, so let's go through this in some detail because this is extremely important. So the window width of a CT scan determines the range and contrast of CT numbers that are displayed on your image. So a narrow width provides higher contrast than a wide width. Okay, so we'll come to this in a bit more detail. A window level is the midpoint brightness level of the displayed CT numbers in the window width. So it controls the brightness of the CT image. And so every single CT that you see has a window width and a window level that's picked by your radiologist. And so if he thinks you're looking at the brain, he'll give you a brain window width and window level. And if you're looking at soft tissue, he'll give you a different window width and window level. But he will be guessing on what you want to see. When you, for example, have a window width of 400, it means that the pixel intensities are from minus 200 to plus 200 Hounsfield units. And if the window length is 30, it tells you that the pixel intensities around the 30 Hounsfield units will appear as white. So you don't need to remember all these details. All you need to remember is that for sinus imaging, your window width should be at 2000 and your window level should be between 0 and minus 200. And I find 0 is a good number to remember. So if you just remember that you went your width at 2000 and your level at 0, you'll get some beautiful images. So I was given this CT scan to review by a radiologist, and it just said, "Can you have a look at the CT, see what's wrong on the CT scan?" I mean, this CT is pretty useless for us as sinus surgeons. It really doesn't give you an airborne interface. It looks burnt out. There is pathology on that CT, and I'm not sure if anybody picked it up. But once you fix the window width and the window level, and you look at the same scan, it gives you a very different look. So you can see now you can really see the airborne interface and the soft tissue and the bone and cartilage really well. And you see, I'm not sure if anybody sees any pathology on that, but you see a very deviated septum and you see something in the left maxillary sinus. Now, this scan is really interesting because this scan was taken in October of 2022. And as you scroll through it, you see there is a little polyp in the left maxillary sinus. And in most cases, we discard that as a mucus retention cyst. But the reason this CT became really important, so these are the window widths and window levels in this particular scan. So you can see what the radiologist gave me was more for brain, and it's not something that was very useful for me. So this is the same patient. So I told you that first scan was in October. This same patient, this scan is in February of the next year. It's February 2023. So that polyp in the left maxillary sinus was likely not just a simple polyp. But again, you see in this scan, with this window width and window level, you can actually see that the tumor is going into the orbits, going into the brain up here a little bit. And so it actually gives you more information than the scan that we usually see for sinuses. So when you're assessing a tumor that might have invaded into adjacent structures, you might need another window width or window level. So, be careful when you're choosing your window width and window levels because you want to get the best ones for what you're doing. Okay, so now time for you guys to go to work. So let's start with a simple case. So this is a case that we did this week, actually. And I just want you to look at the coronal scan. And when most people, I'll ask them to look at a CT scan, they'll always just look at the coronal scan. And this patient can't breathe. He's got recurrent sinusitis more than 4 times a year. So he deserves to have that septum fixed and probably deserves to have some anterior ethmoid work done. And this is a patient that maybe I would do limited FAS on. But I just wanted you to look at that CT scan, and I'll show you the scan again from the front. And if you look at this scan carefully, you realize that there's a lot of salient features here. So actually, I'll go back and let's see if I can stop it at the particular spot here. I keep sliding back. Let me see if I can find the spot I want. So right there. Okay, so when I look at this spot here, I see that the frontal recess is actually very complex in this patient. So when you're practicing looking at anatomy on a CT scan, do it on scans where there isn't disease, because then you can really see the cells. So you see there's an air pocket up here, there's an air pocket in the center, there's another air pocket above the left eye. And when I asked my fellow what was going on here, the answer was, well, that's the right frontal sinus, that's the left frontal sinus, and I don't really know what this is, but it's most likely an intersinus septal cell, right? But that's actually not true. So if you look at this carefully on a 3D scan, right? So again, this is the same patient. Now we're going through it on an orthogonal 3 planes, looking at the same time. So first, just the coronal that you've already seen. If you take your marker and cut it right through the lacrimal duct on the right side, you see the frontal recess on the right side. And you see a couple of things. You see that the skull base takes off anterior to the anterior buttress, and it's wide. The opening is wide. Now, if I go to the other side and do the exact same thing, so I'm cutting just through the lacrimal duct here, I see again the takeoff of the skull base is more anterior than the anterior buttress or the beak, but it's wide. So the fog level in this case would be negative because the skull base is taking off more anterior than the buttress, but it's wide. Okay, so that's the first thing that I do because I want to see what my frontals will be doing when I'm operating on them. But remember, we had that question about an intersinus septal cell. So this is now looking at the right side, and I'm just looking at I'm pinpointing the agarnase on the right side. And you can see the agarnase on the sagittal quite nicely, and the cell immediately above it is actually the frontal sinus. So this patient does not have any cells above the agarnase cell on the right side, right? So that's good. So that to me, it tells me that once I'm through um, I'm at the skull base and I'm past the basal lamella, I will get into the frontal sinus, and there won't be any cells for me to contend with in the frontal sinus. That's on the right side, right? Now that's a very different story than on the left side. Here on the left side, you can see the agar, and it goes pretty far back. There's a pathway above it, which looks like that's a frontal, but look, there's a cell a bit more medial to it, right in the center. Now, if I look at the axial scan, I can see that cell ending dead end up superiorly, as I would expect. And inferiorly, it actually has a drainage pathway just medial to what my fellow thought was the frontal sinus. So what my fellow thought was the frontal sinus is actually not the frontal sinus. That cell in the middle has a separate drainage pathway into the nose, and that actually is the frontal sinus because the drainage pathway is anterior and medial to the drainage pathway of the big cell that was thought to be the frontal sinus. So that's that frontal sinus on the left side, what we thought was the frontal sinus, is actually a supraorbital ethmoid cell because it drains posterior to that cell in the midline. If that cell in the midline drained into the frontal sinus, then that would be an intersinus septal cell. But it has a separate pathway draining into the nasal cavity, and it's just medial to the uncinate process. So very, very complex frontal recess. So when you're operating on this and you get into the supraorbital ethmoid cell, you might think you're in the frontal sinus and you might miss the frontal sinus because all you've done is open into a large supraorbital ethmoid cell. So that drainage pathway, you must correlate that drainage pathway with the sagittal scan and the axial scan. And if you don't look at it in all three planes, you will get lost and you will miss that frontal sinus cell and you will just open the supraorbital ethmoid cell. So very, very important that you recognize this. What I'm trying to show here now is the uncinate process. So you can see the uncinate process on each side has actually all three attachments. It's attaching to the orbit, it's attaching to the skull base, and it's attaching to the middle turbinate, depending on where you're cutting that uncinate. So, when you look at a still image, you have to be very careful because that uncinate can attach in all three planes on the same patient. Then you go into the sphenoid and you notice that there is a partition in the sphenoid. The right sphenoid is more dominant, and that's okay. That's typically the case. One sphenoid is usually more dominant. But when you're looking at the sphenoid, you see I immediately focus on the axial scans. And when you look at the axial scans, you see that the opening of the sphenoid sinuses, the ostia, open into the sphenoethmoid recess directly into the nose and not into the ethmoid cavity. So that's number one. And number two, realize how high the opening is. The sphenoid sinus opening is to the skull base. So when you're going into the natural ostium of the sphenoid sinus, be very careful with your trajectory because if you keep going straight up, you'll end up in the frontal sinus. In the skull base. Now here I'm showing you the posterior ethmoid artery, and the distance of the posterior ethmoid artery to the sphenoid face is 5 millimeters. And this is always the case. So when you dissect, you're into the sphenoid sinus, you follow the face of the sphenoid sinus to the skull base. Remember the posterior ethmoid artery is exactly 5 millimeters anterior to that. And another 12 to 15 millimeters anterior to that is the anterior ethmoid artery. So you've got your sphenoid face, your posterior ethmoid artery, then your anterior ethmoid artery. and immediately anterior to the anterior ethmoid artery, you're basically in the frontal recess. Often I call it the dome area because the bulla lamella can actually come and attach more anterior than the anterior ethmoid artery. The anterior ethmoid artery usually attaches at the very top of the basal lamella and usually behind the bulla lamella. So once you get into the anterior ethmoid artery right here, you'll see a dome, and then you'll see a lamella, and then you'll enter the frontal sinus. So very important to realize that anterior to the anterior ethmoid artery, you'll usually see a cell, and that is the supraorbital recess, which if it pneumatizes, will turn into the supraorbital ethmoid cell. And then after that, the lamella will come the frontal sinus. So a lot of very difficult concepts here that I've been through that I really want you to think about. Now, on the right side in this patient, you see the patient does have like an interlamellar cell that drains into the frontal sinus. And I just showed that to you very quickly at the very end. I'll just play that last bit. So that's the anterior ethmoid artery on the right side. And then there's the dome. That's the next thing. That's a supraorbital recess. And then there's a lamella. And then you're into the frontal sinus, okay? But that frontal sinus on the right side actually has pneumatization right there. And that's what you could call an intersinus septal cell or intersinus frontal cell because it drains into the right frontal sinus. So I hope that wasn't too confusing. So let's go through all of those things in a bit more granular way so we can break it down a bit. So when you look at the uncinate insertions, in the books, you have three types, type A, type B, type C. Type A is the most common in about 70% of patients. But what you need to realize is that all these three types of uncinate insertions exist in every patient, depending on where you cut, when you look at which coronal cut you look at. So don't be too focused on saying it's a type A, because it may be a type A in one cut and a type B in a different cut, and a type C in a third cut. The importance is to correlate the frontal sinus drainage pathway to the uncinate insertion. So if it's a type A, then the frontal sinus drainage pathway is draining into the middle meatus. And if it's a type B or C, then the frontal sinus drainage pathway is into the infundibulum. So if you look at this here, so in 66% of patients, it'll be like 2/3 of the patients will be a type A, that'll be more dominant. And in a third, it'll be either a type B or type C. So if it's a type A, your drainage will go into the nasal cavity. If it's a type B or C, it'll go into the infundibulum and out through the maxillary sinus ostium. All right. I hope that's really clear. So here you can see on one cut an uncinate that's going all the way up, and that's the dominant uncinate. So the drainage pathway of the frontal sinus in this case is through the maxillary sinus and out through the infundibulum. Very important concept. So when you're operating here, you want to make sure that you know when you take out that uncinate, on which side of the uncinate you're going to travel to get into the frontal sinus. Okay, so I just want to now really simplify things and do a line diagram for you guys. So this is looking at a sagittal plane. There's a nostril in the front. The uncinate process has been drawn in, and the ethmoid bulla has been drawn in. Okay. Now I've just added to that the middle turbinate. The middle turbinate has four very important parts. The anterior buttress, where it attaches to what everybody calls the beak, which really is, and should be called the anterior buttress. There's a vertical portion of the middle turbinate, and then there's a process where it curves and attaches to the orbit, and then there's a horizontal portion that goes and attaches to the posterior buttress. So there's an anterior buttress, a posterior buttress, a vertical portion, and a horizontal portion where it makes the transition. So your entry into the posterior ethmoids should be just above this inflection point, just through there. And so when you go in, when you go through this basal lamella, you want to go, instead of going straight up and into the brain, you want to turn and go towards the sphenoid sinus. And remember, the height of the ethmoid cavity will change depending on the skull base. So that's the superior turbinate added in, that's the sphenoid sinus added in, and there is the skull base. So that skull base can be very low or can be fairly high. So when you enter here, if this is very low, you'll be very close to the skull base and you need to make your turn very quickly. My friend who I trained with, Professor Winston Vaughn, calls this the fence. This is the neighbor's yard. This is your yard. And you need to bring this fence right down so you can enter the sphenoid directly as opposed to at an angle. All right. So if you're going in, this is your trajectory. And if you keep going in the trajectory, you'll go into the brain very quickly, particularly if the skull base is farther down. So you need to make the turn, and the turn is extremely important. So here is a case where the surgeon didn't make the turn. This was fairly recent and went into someone's brain and damaged the patient. So you want to be very careful that this doesn't happen. It's called the lost surgeon. So the sphenoid face, we talked about it a little bit. The attachment of the superior turbinate into the sphenoid face is called Parson's ridge. And this ridge can be located in different faces, different parts of the face of the sphenoid. So if this is the septum, the insertion can be very close to the septum or all the way by the orbit. So we did a study on a patient, we did a study on this because a patient got injured by entering the sphenoid with an instrument. And so we decided to try and figure out how often these insertions occurred. So a type A insertion is when the Parson's ridge is in the medial third of the sphenoid face. A type B insertion is when the Parson's ridge is in the middle third of the sphenoid face. A type C insertion is when it's in the lateral third, and that happens in 19% of cases. And that's really important. So if you're coming in here and you think you're way out here, but you're very far out laterally, the optic nerve and the carotid can be very close to you. So when you enter here, you can hit the carotid very easily, which is what happened in our patient. And type D is actually insertion in the orbit. So if you're coming in here thinking that you're far out lateral, you're not. You've been duped, and you're right by the orbit, and you can enter the orbit. So here's the insertion in our patient, and you see my student came in through here, and what do you think was sitting there? A decent carotid artery and a carotid injury. Okay, so this is very humbling, can happen to the best of us. And we can have a whole talk on complications, which is a really important talk, and discuss on how to deal with complications. And I'm sure Nawaf will organize a talk like that at some point in the future. The disadvantages of cutting the superior turbinate: increased bleeding. There's an increased risk of a CSF leak if you're not careful, and I've seen that happen. I've got a nice video of it. You can get an increased risk of hyposmia or anosmia, although we did a study on this and we found that that wasn't true, that cutting through the inferior part of the superior turbinate does not cause any anosmic problems. So I just want to spend about 5 or 10 minutes just on frontal sinus, because we talked about this quickly, and this is really the most important part of your surgery. So as we say, the pre-op CT review is critical. Image-guided surgery should happen up here. And if you've really reviewed your CT scan, you won't really need your image-guided system. So we've published a paper on this for those of you who want to read it. It's an excellent paper talking about this. We are now doing our phase 2 and phase 3 studies on this to try and do an AI generation to come up with a FOD for patients. So when you do this, when you look at the CT scan, the sagittal cuts are extremely important in the frontal recess. So this FOD concept is based on the statement that the more anterior the position of the frontal sinus ostium in relation to the anterior buttress or the beak, the more difficult will be the surgical access to the ostium. And I'll show you that all in diagrams. And the width of the opening is also very important. So we've gone through this very quickly early on, but now let's go through it in a bit of detail. So the ostium is the narrowest area of transition from the frontal recess into the frontal sinus, right? So if the frontal sinus ostium, if the upswing is posterior to the anterior buttress, then that's considered a FOG positive and an easier case Then if the upswing is anterior to the buttress, in which case it's a FOD negative and a much harder surgery to carry out, particularly if you rip the mucous membrane out in that opening. The diameter of this opening is also very important. It can be less than 7 millimeters, in which case it's considered narrow, or more than 7 millimeters, in which case it's considered wide. So the way we did this is we created two lines, a reference line and a secondary line. So the reference line is simply a line that you drop off on a sagittal scan that's cut just at the level of the lacrimal duct. And that line will just be at the level of the anterior buttress or the beak. And then the secondary line is the line that we draw just at the upswing of the skull base. If this second line is behind the reference line, then it's a FOD positive because the S is posterior to the R, and this is the easiest frontal recess for you to dissect in. So when you're doing your first few cases, particularly as a staff person, make sure you're only working on FOD positive cases as you build some confidence. So again, a FOD positive, okay? Just to remind you of what it shows. Now, a FOD neutral is when the two lines overlap each other. So the upswing and the buttress are exactly at the same level. And this makes life a little bit harder for you. And so I would wait to do these cases after I've done a bunch of FOD positive cases. These cases I really worry about. This is when the reference line is behind this secondary line. And to do this operation, you would need to actually find your way around the corner, and the level of difficulty becomes very hard. So if you're, in your first year of working as a staff person, I would not take on a case like this. This is for very tertiary advanced sinus surgeons. And so we did this study and we found that in about 69% of cases, there were FOD positives. In 10% of cases, there were FOD negatives. In about 15% of cases, there were FOD neutrals. So in about 25% or a quarter of your cases, you're going to get into trouble if you're not well-versed frontal sinus surgery and if you don't have the right equipment. So I'm going to end with this patient of mine that I first saw in 2006. Now, you guys are all experts at reading CT scans now. And the first thing that comes to mind when I look at this coronal CT scan, which is the only scan I had in 2006, and where we did a surgery without any image guidance, the interesting thing to notice here is the drainage pathway of his frontal sinus. As you travel back, you notice that the skull base is very low, very low. So this is most likely a FOD negative. Now, back then, we didn't have sagittal reconstruction, so I have to be really careful operating on this patient. But you can see very, very low skull base anteriorly. Look at this, super low on both sides. Seems to be narrow. So when I'm operating here, I have to be very careful. And there's a very high risk that I could plug up those sinuses if I'm not careful when I'm doing his sinus surgery. So that's him in 2006. This is his sagittal reconstructed now. I did this yesterday on my computer, and you can see the FOD. His upswing is way anterior to the buttress, and there's inflammation just at the entrance of the frontal recess. Very scary case to do as an early staff surgeon. When I return, there's the septum. Now we're looking at the right side, and you can see on the right side, it's just as bad, except he doesn't have inflammation. So very, very difficult case for you to do. If you were a young staff person, this is a case I would be happy to send away and say, I really don't want to do this case because I could get into trouble very easily. This is him coming back to see me in 2022. So he disappeared. I did his surgery as best as I could in 2006. He comes back and sees me in 2022 saying, I've been doing great, but more recently I've been getting headaches and postnasal drainage, and I feel like you need to operate on me again. Again, the right side looks great, but on the left side, you can see I wasn't a very good surgeon. because I left behind a couple of little shells that created inflammation, but I didn't rip out his mucous membrane. He's got a large, what you would call a beak, and so that needs to be dealt with. So this is him in 2024. This is now, and you can see that the drainage pathway has been widely opened with a draft 3, right? So we had no option on this patient other than doing a draft 3 and creating a nice open pathway. And you can see that's the upper part of the septum that's gone. And so I am one of those very conservative surgeons who will only do a draft 3 if my primary cases fail. And you can see this is a beautiful draft 3 that has stayed open. And this, I took a picture of his frontal recess yesterday, and it's nicely mucosalized and completely clear and free of infection. So remember difficulty levels based on FOD ratings. So we've come up with this most easy to hardest when it's a FOD negative and the narrowest diameter. So very important. Next phase is to create an AI learning for a quick answer on difficulty level. So you would just put it into your app, and the app would tell you the difficulty level, and then you can deal with it. So this is not my case, but this is a very interesting case. I'm going to just mute my speaker, but you can see that not only is it a FOD negative, but it has a cell in the frontal recess. So it's got a supraorbital ethmoid recess right there, or supraorbital ethmoid cell, that's going to make this very, very hard. And my suspicion is that the surgeon will go in here and go into the brain, which is exactly what happened. So this is the same patient where a CSF leak did happen just as predicted. And you can see the surgeon is operating with an image-guided system. The surgeon is lost and has gone into the funnel, into the brain right there. You can see dura and brain right there. So very, very dangerous if you don't know what you're doing. I'm going to end now, and I'm going to end by saying that this is your art. Become incredible at it, become amazing at it, and please enjoy every day at work. And if you're not enjoying, then you're doing something wrong. So I'll stop sharing so we can answer questions and discuss a little bit. I don't see a whole lot of questions. I don't think I was as clear as it shows on the chat box, but if there are any questions, please feel free to put them in the chat box, or join in and ask your question in person. We have about 15 minutes left. No questions? Namav? Okay. What are the indications for draft 3 procedures? So that's a great question. In this day and age, I think the indications have become less and less with the biologics. Really, the indications used to be that if a really good draft 2B fails, and if you cannot keep that sinus open with topical Pulmicort or budesonide, then and the patient was symptomatic, then you have to do a draft 3. I have to tell you, over the years, I've had hundreds of AERD patients where I've not actually seen a draft 3, where I've not had to do a draft 3. In most cases, a very good draft 2B will work magnificently. So I think that in most cases, you don't really have to do a draft 3 in this day and age because biologics will control the inflammation really well. The other reason why you might need to do a draft 3 is tumors. So in tumors, you really have no choice, and in trauma. And by trauma, I mean iatrogenic trauma, where somebody has gone in and completely destroyed the frontal recess, and there's no hope in getting that open because the mucous membrane has all been ripped out. How does FOD relate to IFAC system? So The IFAC system really, in my opinion, is nothing more than a glorified acute frontal sinus staging system. The thing that the IFAC system looked at, which was, in my opinion, was not just the cells above the agar, but the cells behind the agar. And if you look at Kuhn's system, he talks about the supraorbital ethmoid cells, supraorbital recess, very similar. If you look at the European paper, again, very similar. The FOD system is not a system on its own. It's a system that's meant to complement all the other systems that are out there. All we're telling you to do is look at the scan from a sagittal perspective at the level of the lacrimal sac and see where the upswing of the skull base is. I mean, all the cells in the Kuhn system and the IFAC system and the EPO system, I think they're all the same. They just rename the cells over and over again with their own names. But essentially, what you want to do is not be reliant on those names, but to build the 3D system in your head. And if you can do that and look at the sagittal scan, I think you would. It's a very good tip, is what I'm going to tell you. So start, make a sagittal cut, make the cut at the level of the lacrimal sac, draw your reference line at the level of the anterior buttress, or the beak, as you call it, has become very popular. I think beaks are only in birds, but it's become very popular. And then the second line will be at this upswing, and you just see where the second line is. And depending on where that upswing is and how narrow that is, it'll make your life so much easier, and it'll make this your ultimate image guided system. Right. Okay. So Tracy said the close-up system. So when you, Tracy, I like your question. I'm going to put up my slides again so we can go through the very first. Let me see if I can scroll through this quickly to the very first slide, because we can go through the close-up system. In the close-up system, I want you to do that every single time that you're looking at a CT scan. So here's our first scan. So when you're looking at the CT scan, right, your C is your cruciform plate. So when you look at your cruciform plate, the most important thing that you want to look at is your Kuros classification. And I didn't have time to go through everything in super detail because Nawaf only gave me 20 minutes and actually took up about 40 minutes. But when you look at your cruciform plate, right, the area that you want to pay most attention to is at the level of your anterior ethmoid arteries. Now, remember, the anterior ethmoid arteries are not going across perfectly straight. They're going across at an angle. So they're aiming anteriorly, like an arrow aiming anteriorly out of your face. And so when you look at that anterior ethmoid artery, you stop and you look at the depth of your olfactory fossa, and it won't ever be exactly symmetrical. In this case, you see the left side is higher than the right side. And when you're operating on the left side is higher than the right side. When you're operating in this patient, the left side, if you're a right-handed surgeon, is actually the easier side. I can guarantee you that your first CSF leak will be on the right side, not on the left side. So when you're operating here, you're naturally operating away from the cruciform plate. When you're operating on this side, you're naturally operating towards the cruciform plate, and your first CSF leak will be right there. And when it happens, don't worry. You'll know how to fix it. You just fix it and you repair it, and the patient will be fine. So cruciform plate, very, very important, okay? The other thing that you want to look at while you're doing this is your lamina peperation. What's really important with the lamina is not that whether it's dehiscent or not, which is what most people talk about, but where it lies. If it lies lateral to the natural ostium, you have a wide ethmoid cavity, which is going to make life a lot easier for you than if it lies medial or on top of the natural ostium, in which case it's going to be a narrower ethmoid cavity and much harder for you to operate in. Okay. The other thing that you want to look at when you're looking at the skull base here is how high the skull base or the cruciform plate is from your base basal lamella, your horizontal portion, because that will determine how much space you have in the posterior ethmoids. Because if that gets very narrow, then you're going to get into trouble and get into the brain if you don't make your turn like I told you to make. So the width of this and the height of this become very important. A lot of people talk about the height of this compared to the height of the maxillary sinus. Makes sense because if this is higher, this will be lower and it'll be narrower. So you can either look at this height and say, oh, okay, well, this is getting narrower because this is getting wider. Makes total sense. So that should make sense. A lot of people will look at the roof of the maxillary sinus to find where the sphenoid ostium is. I don't like doing that because I don't like making huge enterostomies, only because I'm a very conservative surgeon. I don't want to lose all the good nitric oxide and I don't want to create a lot of dryness in the maxillary sinus. So a very good way to find your sphenoid ostium is to find your natural ostium, find your find your superior turbinate, remove the lower edge of the superior turbinate when you're starting out, find the natural ostium, and then enlarge it. As you go posteriorly, you start looking at your orbit, right? Because your orbit becomes much more important posteriorly. And as you get closer and closer to the medial rectus, as you go posteriorly, any entry into the orbit posteriorly is going to damage the medial rectus. Anteriorly, you're very safe. Posteriorly, you're unsafe. So remember, when you start operating, make the orbit your friend very early on, so that as you get further back, you're following that orbit and you find your retromaxillary cell, which is one of the most missed cells. Okay, so we've done the lamina, we've done the orbit. We're now getting close to the sphenoid. And as you get close to the sphenoid, you switch to the axial scan because you want to see where the superior turbinate is attached to the sphenoid face, and that's called Parsons ridge. If you've got this much space between the superior turbinate and the orbit, you're in heaven. This is a really nice, I picked this scan because it had all really nice findings for your close up. And then the sphenoid sinus, you can see the superior turbinate actually moves away to a more sort of middle third as you go back. So it pushes you towards the orbit. So when you're starting out, always a good idea to remove part of the inferior edge of the superior turbinate and then find the natural ostium right up here as you enter the sphenoid. When you enter the sphenoid, make sure you enlarge that opening inferiorly, right? And medially before you go laterally. You can use a kerosene, you can use a mushroom punch, it doesn't matter. But this opening should be at least 5 millimeters. All your openings should be at least 5 millimeters. That's the magic number because beyond that, it's unlikely that it's going to close down. But less than that number, and there's a high risk that your openings might close down. And then the last thing, Tracy, is your uncinate process. And we've been through that in a bit of detail. And as we're getting short on time, I won't go through that in too much further detail. But if you see this, there's your uncinate, there it's starting up. And you see very anteriorly that recessus terminalis, where it joins the orbit, is actually part of the agar. It's the agar that goes back and makes the recessus terminalis. So that's very important for you to understand. And then as you go a few cuts back, you see it turns in and gets into the orbit. Here, it sort of turns in, there's a little break in it, but it turns into the orbit. So this is your recessus terminalis. So very important, if I was operating here, I'd find the recessus, I'd find the uncinate, and then I'd go around the uncinate to go into the frontal sinus. Similarly here, I would do the same thing. So very important to figure out exactly what the uncinate is doing. Like I told you, in 66% of cases, 2/3 of cases, it's going to end up dominantly on the orbit. Very rarely will it completely end up on the middle turbinate or the skull base. All right. And that's your close-up.